So we've heard from the talks about, even though ORIF and fixation can have good outcomes, there's a significant rate of complications and reoperation reported in the literature, and you can see all the complications listed here. And when looking at these failed cases, it's often multifactorial, so there can be patient-related fractures like we've heard, fracture type, presence of osteoporosis, smoking history, technical failures. John went over this nicely, that can lead to hardware failure, symptomatic hardware, non-union or malunion. And then there can be late failures. We can get late avascular necrosis with articular collapse and progression to significant post-traumatic arthritis. So how do we evaluate these patients? I'll start with history. I want to rule out any concern for infection that could be present, and then identify some of these patient risk factors that can contribute to failure. I'll look at age and activity level to determine if this is a patient I can consider for revision fixation, or are they going to be someone I'm thinking about arthroplasty on. With regards to physical exam, we can look for signs of mechanical symptoms that may suggest intra-articular screw penetration. We want to evaluate the rotator cuff and biceps for symptoms. We want to do a neuro exam and rule out any concern for axillary nerve injury from the first surgery. And then we want to assess range of motion for stiffness. You can in particular see forward elevation loss with either tuberosity or varus malunion or plate impingement like you can see here. And then there can be significant rotational loss if there's extensive soft tissue contracture. With regards to diagnostic testing, we can get inflammatory markers if we're concerned about infection. We can get an EMG if we're concerned about nerve injury. And then with imaging, I think plain radiographs can give us the cause of failure in most instances, but CT can sometimes be helpful to detect more subtle intra-articular screw penetration like you can see in the videos on the right. It's also important for preoperative planning. We can determine if revision fixation is possible